Thank you for the invitation to address the audience. I have a confession. I'm not a dementia care expert at all, but I have worked in palliative and end-of-life care for about 30 years as a nurse. And one of the things that has become clear to me in my work is that it doesn't matter whether you have cancer or dementia or heart failure or COPD. The issues around end-of-life care are important to all of us because, of course, death is a predictable outcome for all of us. So I'm just gonna see where, many of us would strive to live a life like this woman. Her name is Isabel Melko. She's 103 years old. She lives alone in her own apartment. She does all her own cooking and grocery shopping and all of her own banking. She doesn't have one chronic illness. She's on no medications except for a little bit of plain Tylenol every once in a while when her legs are sore from the 100 years or so that she's spent walking. She has only been hospitalized once in her life. That was last spring. She fractured her pelvis, and to the amazement of everybody in the hospital, she walked out a week later, and she's still at home. She has no cognitive deficits at all, and this picture was actually taken this past summer after a fishing trip that she went on with at the Lake of the Woods in Kenora, Ontario, with her 84-year-old son and her 50-year-old granddaughter, who is me. And I, after hearing the presentations this morning, I'm particularly encouraged that I'm hoping to follow in my grandmother's footsteps, because she could be the poster child for healthy aging. I have never met somebody at 103 who has not had a chronic illness. Unfortunately, in Canada, the situation sometimes is a little bit more like this. George Cook is a man that was in one of our care facilities on Vancouver Island. I had the opportunity to interview his daughter. George was in a Parksville care home, and he had a lot of, him and his family, according to his daughter, had a lot of advanced care planning conversations with family. They had made it very clear that if George was going to be sent to the hospital, that they wanted to know immediately, because they wanted some input into deciding whether or not that would be a good decision. But as often happens, more often than we want, George got sent to the emergency room at the Nanaimo General Hospital and died there. And when I spoke with his daughter, basically what she said is that when she arrived to see George, that he was lying on a stretcher at the entrance to where all the ambulances are brought in. He had dementia. He was restrained. He was completely confused. He was alone. He was soaked in his own urine, and he remained that way for 7 hours, in which then he died, not ever having been seen by a physician. And that, when I talked to the daughter, what she said to me, her explanation for this was, George was just medically uninteresting. Medically uninteresting is unfortunately a term that actually a lot of families have said to me in my studies in end-of-life care, because it doesn't matter if you have dementia or you have cancer or you have late-stage COPD. People who are dying seem to be a little bit medically uninteresting these days. If George had been lived and been admitted to acute care, this might be what we could see. Oftentimes, admission to acute care for older adults and very many people at the end of their life comes together with an intensification of care. And we know that intensification of care at the end of life is associated with a worse quality of life for the patient in their final days of life, a worse quality of death for sure, and an increase in stress, anxiety, and post-traumatic stress disorder for family members. It also happens to cost the healthcare system quite a few dollars. We have a bit of an idealized notion about what dying seems to be. We have this sense that when we're dying, we're going to be at home and we're going to be in the comforts of our home, surrounded by our family and friends, and all is going to turn out wonderful. That's what we all like to think, and that's how we have idealized dying. But in actual fact, in Canada, about 70% of all people die in either an acute care setting or a residential care facility in Canada. These statistics are from British Columbia, but they're not all that different across Canada. 70% of all people who die in inpatient care settings. If we think that the care quality in acute care for folks with dementia might not be what we hope it will be, we can ask ourselves the question whether things are any better in residential care. And I think that Carol has painted a picture of some of the symptom issues that come into play when people are at the end of life with dementia, with dyspnea and pain and pressure ulcers being quite prevalent in a large number of folks. Part of the issue around end-of-life care for people with dementia has to do with the difficulties of diagnosing the terminal phase of illness. And this means that few people get identified as dying until the last few weeks, and more often last few days of life. And so they have lived out their time with those symptoms in play for quite a while. Many healthcare providers are ill-equipped and are unprepared to care for people who are dying, and support for residents and patients and families is often non-existent. In our studies that we've been doing in acute care, one of the things that has really stood out for me is in healthcare providers saying to us that these patients don't belong here. And I keep asking the question back, where do they belong? Where do these people belong? Because quite surely, palliative care units will never be able to handle the volume. Quite surely, palliative care specialists will never be able to handle the volume. And we have 70% of our population dying in these settings with limited access to palliative care and a very poor quality of care at the end of their lives. I'm very hopeful for the presentations that I heard this morning and the attempts that are being made to slow down the progression of dementia and to look at prevention of dementia. But at the moment, dementia, at least in my mind, is a progressive terminal illness that currently doesn't have a cure. And people with dementia have significant health care needs in our system. So we really require an approach to care that is going to enhance care quality and the quality of life of people dying with dementia, and that are going to keep them out of hospital because, while the providers say to us they don't belong here in acute care, they really don't belong because actually they do a whole lot worse when they're there. So I've been working in British Columbia with a group, leading a group called iPanel. It's a team grant funded by the Michael Smith Foundation for Health Research, and we have been working hard at looking at how it is that we could best integrate a palliative approach into the care of people with advancing chronic illness. So we're working with people who have dementia, people with heart disease, people with end-stage lung disease, and we're coming at this issue saying we don't really think that this idea of giving everybody access to palliative care is necessarily going to meet the demand that we'll be facing now and into the future. But we are saying that we need to have an approach to care that adopts the foundational principles from specialized palliative care and adapt those to the unique needs of people with dementia. We need to embed this knowledge and expertise upstream into the care delivery of people across healthcare sectors and capacitate those who work in these settings to provide quality end-of-life care to people with dementia. We know that if we don't tackle this problem now, we will continue to have the problems as we go down the road. I've worked in palliative care for 30 years, and while I've seen really great strides, I'm sad to say that some of the things that I saw in my practice 30 years ago still exist today. And I think it's an issue that will be important to all of us as we age, if it hasn't already become so in your own families.